I share my screen. Thank you for this introduction. Special thank for Dr. Azam for sharing me in this important conference. My talk today will be about invasive strategy for patient suffering from ST elevation myocardial infarction. Really, this is my agenda, and I have to inform you that I am coming from background of primary BCI center. We didn't use any thrombolytic since 2013, and we do in our center about 600 cases of primary BCI. I am the program director of myocardial infarction management, and we didn't use any thrombolytic since 2013. Even so, I am, to some extent, I severing this strategy of pharmaco-invasive in special cases, in special situation, and also especially for cases which is referred from other centers. This is upon what we are severing during the last 9 years of our experience of primary BCI. My introduction, there is no doubt that timely performance of primary BCI in ST elevation MI patient by experienced team is superior to fibrinolysis. As clearly confirmed by the famous meta-analysis of Keeley published in 2003. And since this publication, the number of both cath lab and the primary BCI procedures are increased exponentially across the world. A key question, however, is what is timely performance of a primary BCI? In this regard, the current European Society guideline states that primary BCI is the preferred procedure if it can be performed by experienced team within maximum 120 minutes from ST elevation diagnosis by ECG to wire time, and it is preferred according to the European recommendation to be done within 60 minutes for primary centers, which is one of our KPI in our center, to be less than 60 minutes or to be less than 90 minutes for cases referred from other hospitals. Recommendation to within 120 minutes is derived from outcomes seen in randomized trial and large observational study. The guideline usually refer to the study which was done by Pinto from the National Registry of Myocardial Infarction in the United States, which has shown that in two matched population for almost more than 10,000 ST elevation MI, and primary BCI usually loses its survival advantage at 30 days over in hospital lysis if the BCI related delay is more than 120 minutes. So timeline and the time fashion is very important when we are dealing with ST elevation MI patient. This is the recommendation, as I mentioned before. The optimal time is less than 60 for primary BCI center and less than 90 minutes for cases referred from other center, but it is acceptable to the maximum to be less than or 120 minutes. Right. What about reperfusion therapy? Really, primary BCI is the gold standard. No one can discuss this, but is this time fashion achievable in different time of the world? The answer, no. To afford ideal time for primary BCI, you have to have first in-house 24/7 full team not only interventional cardiology. You need full team in hospital, which is not easy. Critical beds should be available. Second team should be available on time if many cases present at the same time. I cannot forget one of the weekend, 3 weeks before, I accept 4 cases for primary BCI coming within 1 hour to our center. So also transferring the patient from first referral hospital to interventional center at time fashion, which not visible in majority of cases. We are suffering a lot from this issue. We get a call from another center, they have case for primary BCI. We tell, please shift the patient directly. After 1 hour, we call again back, the patient still in the hospital, not moved. We are suffering a lot from our practice during the last 9 years from this issue, as I mentioned before. What about the what is important also for patients who are referred from other center to primary BCI center is the time in and time out, door in and door out time. This is very important and should not exceed 30 minutes as the recommendation coming from the performance measure in the United States. And if we exceed this 30 minutes, our achievement, it will be acceptable. And this is the timeline. This is very complex, especially for patients referred from other centers. We have to check the first medical contact, then diagnosis, then the patient departure, or this is challenges. Then patient reach our primary BCI center and triage, then ship the patient please to the cath lab, or the team is available, 2 cases or 3 cases sometimes coming at the same time. There is a lot of challenges facing to do primary BCI by default for all patients. Really, I can tell that. And as I mentioned before, only for patient referred from other centers, within less than 30 minutes, only according to this national registry, only 11% can be shifted within less than 30 minutes. And this will affect our result. If it is less than 30 minutes, door to balloon, it will be less. So survival and mortality, it will be significantly different. So if we compare here, if the door in, door out is less than 30 minutes, the mortality, it will be 2.7 compared by 8.3 if this time is more 91 minutes. And also other questions. Are we performing BCI within time? Roughly, according to international registry coming from different parts of the world, you can tell roughly half of the ST elevation MI patient receive timely reperfusion, either for fibrinolytic therapy or for primary BCI. And also, is primary BCI for ST patient in the Europe available for all? No, even especially for other region, I mean Africa or Middle East, which is estimated only to be up to 43% is available from this international register, new international register. So what about pharmacoinvasive? If fibrinolytic therapy has been chosen as the primary reperfusion therapy, subsequent angiography and possible BCI of the infarct-related artery should be done, which is named pharmacoinvasive therapy. In pharmacoinvasive strategy, patients who receive fibrinolytic therapy are transferred immediately to a BCI-capable hospital for early coronary angio and BCI, generally in 2 to 24 hours, or for rescue BCI if indicated. This is according to the European Society recommendation. And this is the timeline, as I mentioned before. This is for rescue BCI. Patients should be evaluated, as I mentioned, after 60 to 90 minutes from the thrombolytic therapy to evaluate if it is successful or not. And even if it is successful, BCI should be formed between the time 2 to 24 hours. We have to respect the first 2 hours and avoid to do BCI for successful thrombolytic therapy within the first 2 hours to avoid hemorrhagic or bleeding complication. What is the rationale regarding this pharmaco-invasive therapy? The rationale for that many patients have persistent reduction in flow in infarct-related artery post fibrinolytic therapy, and those are at risk of reinfarction. And also fibrinolytic restore patency TIMI 2 or 3, but we need TIMI 3 percentage to increase the outcome. And this is only achievable in 50 to 60% of patients managed by fibrinolytic therapy. As I mentioned before, clinical benefit of lysis are seen only when with restoring of a normal flow, I mean TIMI 3 flow. And this is the result from GOSTO 1, that 30 days mortality is related to what we achieve by TIMI. If it is TIMI 3, there is significant reduction compared with TIMI 0 or 1 after thrombolytic therapy. So this is one of the major reason supporting pharmaco-invasive therapy. Here you can recognize how it affects the survival. If it is TIMI 3, the survival, it is significantly better compared with TIMI 0 or 1 or 2 after thrombolytic.
Dr. Baba, you have only 2 minutes left.
Okay, sorry. What is the evidence? We have many evidence supporting pharmaco-invasive therapy. One of them, which is a French FAST MI registry, which is newly analyzed, and also from STREAM trial, also which is a huge trial supporting this. In FAST trial, MI registry, French registry, we compare 5 years outcomes regarding timely primary percutaneous intervention and for group of late primary percutaneous intervention and pharmaco-invasive strategy. You can conclude that timely BCI and pharmaco-invasive strategy have similar prognosis. On the other side, late BCI associated with increased of adverse outcome and increased mortality and decreased survival. This is also from Vital Heart Response Registry. Also, pharmaco-invasive strategy showed better outcome compared with primary BCI, and this is Mexico registry, and this is from Norway also registry. This is STREAM trial, which also shows that no difference in the primary composite outcome between primary BCI and pharmaco-invasive strategy. and this is the Norway also registry, the same message. And even with pharmaco-invasive, the survival benefit is more, especially for patient coming in the first few hours. So, is bleeding is higher with pharma? Yes, it is higher regarding intracranial hemorrhage, but we can reduce it too much by conscious of dosage and combination of additive medication, and to be adherence with medication regimen that matching each special group, and special recommendation for elderly, especially patient over 75 or sometimes.
Dr. Bassam Baba, sorry for interruption.
Yes, I conclude.
Please go to the conclusion. Okay.
Pharmaco-invasive therapy has shown comparable results with the primary BSCI evidence for ST elevation MI. In the real world setting, pharmaco-invasive may be preferred approach when BSCI delays are expected. In the absence of contraindication, license should be considered if a primary BSCI is not available in less than 24 hours. Deny this therapy can be considered unethical for early presenters less than 2 to 3 hours with no contraindication of primary BSCI is not available. Finally, lysis is not a final treatment. It should be completed by immediate transfer of patient to primary BSCI center for reperfusion assessment at 90 minutes, followed by urgent rescue or planned angio at 2 to 24 hours. Thank you for your attention.